Welcome to the AUANews Inside Tract podcast, an official podcast of the American Urological Association. Thanks for listening. For more episodes of this podcast, visit www.auanet.org/podcast.
Hi, everyone, and welcome to AUANews Inside Tract. I'm Mark Edney, chair of the AUA's Public Policy Council. And today I'm joined by Dr. Helen Burnie to discuss a major development in men's health. On June 18th, the FDA announced it is requesting updates to testosterone therapy labeling following a review of new clinical data. Changes that could have important implications for how we counsel patients and think about safety, risk, and access to care. Helen, thank you for joining me today to talk about this.
Thank you so much for having me.
So you are associate professor and director of sexual and reproductive medicine at Indiana University. Tell us a bit about the evolution of your academic interest in men's health.
So first, I am a boy mom. So I have 3 little boys. I have 2 brothers. I have a dad. I have a father-in-law. So I have men all around me. My interest in men's health really evolved from seeing this major gap that we have in how we care for men, right? So as urologists, we oftentimes meet men at a really important entry point into the healthcare system, right? If they can't pee, if they can't have sex, if they can't make a baby, or for me, because I do men's health, if they have Peyronie's disease or prostate cancer survivorship, those visits are often about much more than just that one symptom. So for me, really, men's health is not just sexual health. It's their cardiovascular health, it's their metabolic health, it's their mental health, their fertility, their overall health, preventative care, cancer survivorship. So, this really became very clear, like in my own clinical practice, that a man can come in asking about erectile dysfunction or low testosterone, but that's going to be that first visit that plugs them into the healthcare system. It's where all of a sudden now I can screen them for diabetes. I can screen them for undiagnosed sleep apnea, depression, or infertility concerns or cardiovascular risk. So, I think men's health isn't just about sex. It's often about the doorway into a much larger conversation about their overall health. And so it's really why I've built my academic career around male sexual and reproductive medicine. I see this as a major public health opportunity and a way that we can dramatically improve health in the United States of men, because right now men in the U.S. die nearly 6 years earlier than women. They're less likely to engage in the healthcare system. They die for 9 out of 10 of the leading causes of death. And so every time we have a man and we bring them into care, we have an opportunity to change the trajectory of that. And so that's really what is my passion. I want to know that when I leave this planet one day, that men's health in the United States is dramatically better because of something I helped do.
That's awesome. And that's fantastic work you're doing. And there's so much in what you just said to unpack. And we'll hit some of those major themes as we go through the conversation. But it's phenomenal work you're doing. And thank you for doing it. And I love your enthusiasm for it. Like we said earlier, the FDA made a major announcement on June 18th requesting updates to testosterone therapy labeling. At a high level, what's changing?
So this is huge, and it's very long overdue. So the FDA is requesting 3 major updates to the testosterone therapy labeling. Specifically, first, they're proposing to remove that long-standing limitation of use that effectively excluded many men with age-related or idiopathic hypogonadism from treatment considerations, because these are primarily the patients that we see in our office. These are the men that are coming in for treatment. In plain language, that means that men with symptoms and repeatedly low testosterone levels may no longer be excluded simply because they don't have a clear genetic cause or a pituitary testicular cause of failure, which was the previous indications that you needed to have a genetic cause. Second, the FDA is updating the prostate cancer language, right? This is probably the most common question that patients ask me in the office. The proposed new labeling would limit the contraindication to metastatic prostate cancer rather than broadly warning against testosterone use in men with any known or suspected prostate cancer. And then lastly, or third, the FDA is updating the BPH or benign prostatic hypertrophy language, because current labels have warned that testosterone may worsen urinary symptoms in men that have enlarged prostates. So the FDA review found that the available data does not demonstrate worsening symptoms in men with either mild or moderate BPH. So it's not about opening the door to like this indiscriminate prescribing or that everyone should get testosterone, but it's really about aligning the label with the evidence and the patients that we actually see in clinical practice. And importantly, this follows really the FDA's February 2025 removal of that boxed cardiovascular warning after review of the major Traverse trial that came out with cardiovascular safety data. So, the cardiovascular warning removal is really that big major step. And then this proposed label updates are really the next evolution.
So you mentioned new data and you mentioned the Traverse study. So with between Traverse and other new data, what is the new data and new evidence driving this decision? And how does it differ from what we knew when these labeling restrictions were first put in place?
So the evidence base has changed dramatically from when many of those warnings and restrictions were first put into place. I mean, I remember when I was in residency and the Vigan and Finkel studies came out saying that, testosterone caused cardiovascular risk or heart attacks and major diseases. And so then all of a sudden the FDA put out the block box warning and they requested this study. And so thank goodness, this very important cardiovascular study called the Traverse trial came out. And this was a study where they looked at over 5,200 hypogonadal men that also had cardiovascular risk factors. So these weren't just healthy men with hypogonadism, they were men that had cardiovascular risk factors. And it was a randomized controlled placebo trial where they gave men testosterone and the other group got a placebo. And after follow-up, it showed that there was no increase in MACE or major adverse cardiovascular events in the men that received testosterone compared to the men that FDA removed the box cardiovascular warnings in February of 25. Although it did add, or I guess it maintained the blood pressure warnings where appropriate. So you still need to monitor blood pressure on any testosterone modality that you start a patient on. But this June 18th proposal is much broader than the cardiovascular safety because the FDA also reviewed all the evidence related to prostate cancer, to BPH, to patient selection. And so the available clinical trials and the epidemiologic data haven't shown an increased risk of prostate cancer in men receiving testosterone therapy. I mean, data from my fellowship at Memorial Sloan Kettering, data from our own institution at Indiana University, we've looked at this, and there's been no study in the literature, if you look, that shows that testosterone therapy causes prostate cancer. So they finally removed this, and they do still the FDA still appropriately acknowledges that long-term uncertainty certainly still remains because prostate cancer develops over years, and there's not going to be some perfect study that's going to find and see every risk possible. But I think this is a huge step forward because so many men that had prostate cancer were previously told that they couldn't get testosterone therapy. And then lastly, for BPH, available clinical trial data do not show any worsening of urinary symptoms in men with mild to moderate disease. The Traverse trial, even in their prostate cancer subset study, showed no increased incidence of urinary tract symptoms, increased medications, or diagnosis of prostate cancer in men that have BPH. So I think this has just been so exciting. I also was very honored to have the opportunity to serve on the FDA Men's Health Expert Panel on testosterone back in December 2025, where we had experts from around the country. We reviewed the evidence around cardiovascular safety, prostate cancer, prostate health, screenings, appropriate use of testosterone. So, I think this is kind of exciting because this is like exactly how evidence-based medicine should work, right? A concern's identified, more data is generated, experts review the evidence, and the FDA is now updating this label so that patients and providers can, practice evidence-based care.
That's awesome. Your passion from this shows through. And in fact, you've dedicated your academic career to these topics. And so my next question, and you've started to address some of it, the work that you've done personally, both either policy wise and or in terms of education and research academically, what personally have you been doing to contribute? You mentioned the FDA panel. And so from a public policy perspective, those sorts of participations are enormous for an academic expert like yourself, who's devoted your career to these issues. What's some of the other work that you've been doing, either education and research wise?
Oh, thank you. So, thank you very much. I got my MPH when I was in grad school, like before med school. So that really started my interest and my passion in public health. But a lot of my work now centers around education, both patient and clinician education, clinical care, research, and advocacy. Clinically, I take care of men with testosterone deficiency every day, but I also care for men with prostate cancer survivorship. I see them with those concerns. I talk to men about infertility, about erectile dysfunction, Peyronie's disease, all of that. So testosterone conversations are rarely isolated. They're usually just part of that bigger men's health evaluation. From an educational standpoint, we spend a lot of time teaching trainees, teaching patients, teaching clinicians. How do you evaluate testosterone deficiency appropriately? What are the symptoms? Repeat morning testosterone tests, identifying what are the reversible causes, counseling men about fertility, monitoring, how do we monitor appropriately, monitoring hermatocrits, monitoring PSA, and really discussing risks and benefits. And then from a policy standpoint, serving on the FDA expert panel was extremely meaningful because it really allowed all of us experts to come together to review the evidence in a really structured way. The goal of my work is not to just put more men on testosterone or to say that every man needs testosterone, but the goal is better prescribing, right? The right patient, the right evaluation, the right counseling, and the right monitoring. Because most clinicians weren't taught how to do this. And they have the fear of this testosterone being a class 3 scheduled drug. And everyone just kind of shies away from this. And I think that we're missing a huge opportunity to implement preventative health. So I strongly believe that testosterone should be viewed as a biomarker of men's health. It is one of the most important biomarkers of a man's health. So when a man has low testosterone, I don't just ask them, do you need testosterone? Let's talk about it. But why is it low? What am I missing? Is he obese? Does he have diabetes? Does he have undiagnosed obstructive sleep apnea? Is it medication side effects, chronic illness, cardiovascular risk? I think all of these things are so important, and I love it. I'm very fortunate that we have an amazing fellowship. We have research fellows, we have residents that come through our program, and medical students. And we get to help teach the next generation about this and get to show them the importance. They see patients come into the office every day whose lives are dramatically changed and their overall health, right? Like you have patients that come in and they're coming in complaining that they feel horrible and that they can't even have energy to play with their kids after work, that they can barely walk across the parking lot to come see me in the clinic. And you get their testosterone on tap, you fix their erectile dysfunction, you counsel them about their hemoglobin A1C. And the next time you see them, they have normal testosterone levels. They talk to you about what energy they have again. Their partner is like, wow, this is my husband. I mean, he's back to life. This is who I married. They have such a great improvement in their quality of life that, I mean, you see the impact that you can have by educating them and really teaching them more about their bodies and their conditions and letting them know that if you empower them, they can make these changes and they can improve their overall health.
No, fantastic. So thinking about the general urologist, the urologist out there who sees a little bit of everything. Yeah, they've got a handful of testosterone patients, but they do lots of different things. And so this isn't a major focus necessarily of their practice, but they do it. What's your message to that urologist? How does this potentially meaningfully change how, as a general urologist who does lots of different things, how you think about and prescribe testosterone?
So my husband is a general urologist, but he has drank all my Kool-Aid for many years, so he knows all about this. But I think this is really significant, right? It gives clinicians the confidence to practice evidence-based care rather than this fear-based medicine, and I think it gives them the permission to use the science now. So I hope just like education and awareness of anything, having these labeling changes is going to all of a sudden allow people to feel more comfortable helping take care of this patient population. Because I feel like so many people are just like, it's not my lane, it's not what I want to do. But we have such an awesome opportunity to improve men's health here. So for years, many clinicians felt caught kind of between like what the data is showing and what the labeling suggests, and I don't want to do anything wrong, or I don't want to get in trouble. Because labels matter, they influence prescribing patterns, they influence institutional policies, they influence insurance coverage, they influence patient perceptions. I mean, they influence everything. So I think that the impact of this is even far more reaching than we realize. Now, is it going to change my approach? No. I've been prescribing testosterone, for years. I think it's amazing. I think men and women need healthy hormone levels all their life. I always, the residents will even tell you that I'm very evidence-based when I'm in the office, when I'm teaching. I'm very evidence-based and I'm very individualized, right? So I'm still going to diagnose testosterone deficiency based on symptoms, repeatedly low morning testosterone levels. I still evaluate if they have reversible causes. I'm going to counsel them if they have diabetes. I'm going to counsel them if they're smoking. I'm going to refer them for a sleep study if I think they have obstructive sleep apnea. I'm still going to counsel about risk. I'm going to talk about infertility. I'm going to ask them if they're interested in fertility right before you get testosterone therapy. We're still going to monitor all those things. But I think what this changes is the framing of it all. So, men with idiopathic or this age-related hypogonadism, they shouldn't be dismissed automatically. Men with localized prostate cancer shouldn't be automatically denied therapy anymore. Men that have mild to moderate BPH and urinary symptoms shouldn't be excluded simply because of these warnings anymore. So I think these changes are going to allow physicians to care for patients based on evidence rather than outdated fears.
Sure. And so ingrained attitudes and behaviors are really tough to crack. I mean, particularly amongst clinicians, but also amongst patients, because there's a whole group of patients out there, men, who have been beaten over the years with this notion, and they've been told by clinicians it's not safe for you. This isn't safe. So what's your message directed towards patients, especially those who've been hesitant about testosterone therapy because of past safety concerns?
I hope that it brings more patients into the healthcare system. I hope it gives them more confidence to inquire about their own health and to inquire about their testosterone. I think it means that patients deserve a more balanced conversation from us. I think, for years, men have always heard that testosterone causes heart attacks, it causes prostate cancer, or, all these fears that shape patients' decisions and physician behavior. So, I think the best available evidence doesn't support many of these fears, right? And so when you have an appropriately selected and monitored patient, testosterone therapy can be life-changing. It doesn't mean that testosterone has no risks, right? We talked about some of them: high blood pressure. It can raise hematocrit levels. It can cause infertility. But no medication is risk-free, not Tylenol, not ibuprofen, things we use every day. So I think patients still need appropriate evaluation. They need a shared decision-making with their physician, and they need appropriate ongoing monitoring. The AUA guidelines recommend once you've started someone on testosterone therapy that we're going to monitor them every 6 to 12 months with labs. I think they need to understand fertility. I think one of the biggest misnomers is that I have patients that get sent to me all the time for male infertility. And I get this referral and it's like the doctor said, "Oh, this patient has low testosterone and I'm sending them to you for fertility." So I went ahead and started them on testosterone. I'm like, no, because they think that somehow testosterone improves fertility, and they don't even realize that low testosterone it can harm a lot of men with fertility. It can suppress sperm production. It can significantly reduce fertility in men who want future children. So you really need to have that conversation and counseling before starting therapy. But I think for men with true testosterone deficiency, these symptoms matter: low libido, erectile dysfunction, fatigue, depression, loss of muscle mass, anemia, reduced bone mineral density, impaired quality of life. I think these things matter, and I'm hopeful that they're going to realize that not have this fear of being dismissed. This is just a normal part of aging, or testosterone is just this longevity medicine or muscle medicine or sexual health. That it's a marker of overall health, and that they deserve to have these things addressed and deserve to have these things treated, because it's not about treating a number, right? It's about treating the patient. And so for many men, this treatment can be life-changing when it's used appropriately. And I hope that these changes allow patients to have the confidence and have the drive to start engaging and interacting with the healthcare system earlier.
Excellent. That's great information. So switching gears a little bit, you are a member of the Sexual Medicine Society of North America's Board of Directors. What has SMSNA been talking about and working on with respect to men's health, including issues around T replacement?
Yeah. So the SMSMA, or the Sexual Medicine Society of North America, is an amazing organization. It's the largest organization in North America for male and female sexual and reproductive health. They have been very engaged in advocating for evidence and advancing evidence-based male and female sexual and reproductive health. So, as a member of the SMSMA Board of Directors, I see the organization's role in helping clinicians. They help patients. They help policymakers understand that men's health is broader than any one medication or diagnosis. Testosterone therapy is just one part of that conversation, but the SMSMA also focuses on erectile dysfunction, Peyronie's disease, infertility, ejaculatory disorders, prostate cancer survivorship, sexual medicine education, APP education, responsible communication to the public. I mean, they have podcasts, they have webinars, they have online resources and online articles that are written weekly and put out. But I think a major issue is making sure that patients get accurate information, right? There's almost, in this day and age, there's too much information, right? There's TikTok, there's Instagram, there's LinkedIn, there's all of these influencers and people that are out there talking about sexual health and men's health, and oftentimes they're saying inaccurate information. So I think there's a lot of misinformation about testosterone, both overstating the benefits and also overstating the harms. So I think testosterone shouldn't be marketed casually, but I think it shouldn't also be feared, irrationally. So I think the SMSMA's role, one among many, is to keep the conversation grounded in evidence, patient safety, and appropriate access to care, while educating both patients and physicians.
Fantastic. Yeah, SMSNA has been doing fantastic work in this space for a long time. From a federal advocacy standpoint, we had a huge leap forward this past March with the introduction in Congress of the State of Men's Health Act. The bill seeks to first study the federal men's health assets that currently exist, and then establishes an Office of Men's Health within the Department of Health and Human Services. The SMSNA, together with the AUA and other organizations, have been advocating for an Office of Men's Health for many years. What would this Office of Men's Health do for our country and for men in our country?
So I think this is huge, and I hope that everyone is reaching out to their representatives and they're emailing them and they're letting them know about the importance of this. a federal office of men's health would be absolutely transformative. We already discussed that men in the United States die 6 years earlier than women and have 9 out of 10 leading causes of death. They are less likely to engage in preventative health care. They're less likely to go see a doctor. And yet we do not have any coordinated federal strategy that's focused on men's health. So an Office of Men's Health could actually help study existing federal resources. Where are the gaps? How can we identify them? How can we improve public education? How can we coordinate research priorities, develop strategies, and engagement earlier in healthcare, right? And I think the most important message here is that this is not a zero-sum issue. Supporting men's health does not take away from women's health. When you have healthier, stronger men, that means healthier partners. That means healthier dads. That means healthier families, healthier communities, and healthier partners. Men's health is public health. And so an Office of Men's Health would help move us from this fragmented care to a national strategy of how can we improve men's health in the United States. We have done great things with women's health, the pink campaigns, people getting mammograms, and there is still tons of work left to do. But let's see how we can utilize those same coordinated efforts to improve men's health, because we see that there is a huge gap there and it's not closing.
Fantastic. Well, Helen, this has been a fantastic discussion, and your enthusiasm is matched only by your encyclopedic knowledge and your dedication to advocacy in this space. So really, really appreciate your time and your knowledge. I want to give you the last word, or are there any sort of final thoughts you want to put out to the audience before we wrap up?
Yeah, I feel like I keep repeating myself, but I just hope this conversation becomes much bigger than just testosterone. Testosterone is extremely important. It is a biomarker of a man's health, but it's also a window into a much larger men's health crisis. I think that low testosterone, as I mentioned, it's associated with obesity, diabetes, metabolic syndrome, cardiovascular disease, frailty, increased all-cause mortality. We know ED is a harbinger of cardiovascular disease, that it precedes heart attacks by 3 to 5 years. Yet we don't address these things. We don't talk about these things. Everyone thinks it's someone else's lane or that it's taboo. And there's no routine testosterone screening in the United States. In fact, both the Endocrine Society and the AUA currently recommend against routine screening for hypogonadism. And the rationale is that we lack, screening trial data or this long-term treatment evidence. And I understand the caution, but consider what we do screen for. We check for thyroid stimulating hormone at annual visits with your primary care doctor, right? And there's no long-term screening trial data for this. And in fact, the United States Preventative Task Force actually recommends against routine TSH screening. Yet we check it still at all of our annual visits. We check lipids, we check hemoglobin A1C. And yet here's this hormone that's associated with higher all-cause mortality, with cardiovascular disease, diabetes, osteoporosis, dementia, sarcopenia, frailty. And yet we don't even measure for it. We have this biomarker and we're leaving it on the table. So I just think that testosterone deserves such a larger role in men's preventive health conversations, particularly men that have symptoms or risk factors. But, my goal one day would be that this is something that's an annual screening, because it's often the symptom, low testosterone, but the diagnosis is something much larger. And I think as urologists, we really are the gatekeepers of men's health, right? We have a huge opportunity because men traditionally don't engage in healthcare. But if they can't pee, if they can't have a baby, if they have erectile dysfunction and can't have sex, those are often the first thing that drive them to bring them into the office. And it's gatekeepers that argue that we have not only an opportunity, but we have a responsibility to use these visits to engagement in broader healthcare. We can plug them into a primary care doctor. We can plug them into an endocrinologist. We can plug them in to get a referral for a sleep study. I'm not saying that urologists have to be primary care physicians, but if a man comes in to talk about erections, talk about testosterone, to talk about fertility or urinary symptoms, that might be the first time he's ever engaged in the healthcare system in years. And so this is really our opportunity and we shouldn't miss it.
Fantastic. And we'll let that be the final word. And I suspect you and I are going to be talking again about this really important topic as these issues evolve. So Helen, thank you so much for helping us unpack this really important and evolving issue. This is clearly a moment where new evidence is shaping both clinical practice and policy in men's health. To our listeners, we'll continue to follow these developments closely and what they mean for urology and patient care. Thank you for joining us. We'll see you next time.
This has been an AUANews Inside Tract podcast. Thanks for listening. For more episodes of this podcast, visit www.auanet.org/podcast.